I think that it looks as it passed almost only a few days since we have seen each other. I can see here Professor Ventura, I can see Dr. Čeperković, I can see some other people, I'm not sure. And I'm very happy to see you again here with us on this online conference. And I hope that we will meet soon again live, and that you are going to join us to our institute, and that we are going to continue with our program that looks very well for now. And all these patients that have been operated here are well, and they are very satisfied, and we are also satisfied. And I hope that we will learn something new today, and I know that it is going to be like that. And maybe this is going to be the way that we could exchange our knowledge and your experience, and maybe you won't be we won't need you so often here at our institute. Maybe we will try and we will manage to solve our problems without you, but with you on this online conference. Thank you very much.
Okay, good afternoon. It is a great pleasure to be part of this big day, the first international webinar conference in Serbia. As you may know, my name is Vladimir Jan, and we will now continue with our guest.
Okay, I would like to talk today about the idiopathic adolescent deformity and pediatric early onset scoliosis as well. Well, everybody knows that the scoliosis is a three-dimensional deformity which results from the lateral curve in the frontal plane and a loss of physiological thoracic kyphosis, which is called the flat thoracic spine. And but from the practical point of view, the idiopathic scoliosis in children has been classified in two types. The early onset scoliosis, it's when the curve appears before 10 years of age, and the late onset scoliosis, when the curve appears after 10 years of age. This classification is based on the growth of the chest and the development of the pulmonary system. We know that the pulmonary system can grow by increasing the number of alveoli until 8 years of age. And the 80% of the frontal diameter of the adult chest has been achieved by the age of 4 years. We know that the lung growth cannot proceed properly in a constricted chest by the deformity in very young children. And Bob Campbell specified the term of the thoracic insufficiency syndrome. That means the inability of the chest to support normal growth lung or normal pulmonary function. There are two forms of early onset idiopathic scoliosis in children, the resolving type and the progressive form. The resolving type, it's a benign, flexible curve, which doesn't need any treatment at all, and is usually detected by the time the child is 1 year of age, but without any treatment at all, disappear approximately at 2 years of age. But the second time, which is the progressive early onset scoliosis, this deformity are incapable of spontaneous resolution, and if it left untreated, they can develop the more severe idiopathic scoliosis deformity in children. This is a case typical that a child of 7 months of age was diagnosed to take in relation with a chest X-ray, and they diagnosed our scoliosis deformity. He was sent to my hospital when the child was 17 months old with a very severe deformity. I immediately cast him, and for 3 months, and after that another cast, and you can see here by the age of 8 years of age, the spine was nearly straight. We consider that the progressive early onset scoliosis must be treated as soon as possible, and casting is the best technique for these young children. The question that is often raised is why to correct early onset scoliosis children with cast and not with brace? Well, the problem is that no brace can control the scoliosis so effectively as a cast which is applied under general anesthesia. And in the cast, the child maintains the corrected position for 2.5 or 3 months. So the spine grows in the right position. And something very important, children tolerate very well casting, but not very well brace. So it's difficult to convince them that they have to wear a brace. The technique of casting has changed. In the old days, in the 70s and 80s, we used the Cottrell table, but nowadays we are using a very simple technique. We use 2 boxes for put the child on the head and on the bottom. We apply distraction. We use a stockinette layer. We use cotton under the cast, which is to protect the more prominent parts, and we applied tractions. We try to derotate the spine with our hands. Usually, when we finish that, we open a big anterior window to allow the patient to breathe properly. And we have chosen the 5 years of age as cutoff point for casting application. We consider that over 5 years of age, I think it's better not to put them in cast because it's difficult for them, difficult for the family, and perhaps they can be treated better with a brace than with the cast. But when the cast cannot control the curve and the curve increase, we have to provide other options. For instance, this is a girl who was sent to my hospital from Morocco with a very severe malignant progressive early onset scoliosis. At the age of 4 years, the curve was measuring 180 degrees. We thought that perhaps cast would be a very good option for her, but first we put her in halo gravity traction for a couple of months or nearly 3 months. We achieved a very good correction. You can see here that the curve correct from 180 degrees to 72 degrees, and we put her in cast, but didn't work at all. And when she came back, we decided to use or to put her in growing rods. The growing rods can control the deformity, can correct the deformity, and respect the growth of the spine. But these deformities are very severe, and sometimes they have developed a lot of problems, like broken rods or dislodgement and skin problems and everything. Usually, we have to lengthen the device every 9 months. And we use hooks on the ribs or hooks and pedicles in the upper vertebrae, upper thoracic spine, and a couple of pedicle screws in the lower one. We use 2 rods. We connected 2 rods by 2 dominoes, and usually we lengthen them every 9 months. But because there are very complications in these techniques, I think that the reason for that is that they require multiple surgeries. So the earlier we start the treatment with growing rods, the worse it's going to be in the future, because we have to try to delay the indications of growing rods. One of the main contraindications for growing rods is thoracic kyphosis over 40 degrees. When the patients are hyperkyphotic, we cannot use properly the growing rods. And we think that is one of the main indications for correct the kyphosis, thoracic kyphosis with growing rod. For instance, this is a typical patient to be treated with growing rod. She's 10 years of age, research sign 0, very mature, 70 degrees, right thoracic curve of 70 degrees, and we use growing rods. very good correction after the index surgery, and after 3 lengthenings, we perform definitive posterior fusion. As you can see, that we have achieved a very good correction if we compare with the first preoperative X-ray. So I think that is very important to delay the indications of progressive early onset scoliosis. We can wait more or less till the curve is maximum 70 degrees, 75 degrees, because we are going to achieve a very good correction. And another point, very important for me, is nowadays we don't perform definitive posterior fusion, especially if the spine is very well balanced and in the AP and in the lateral. This is a girl that we treated with growing rods. And after, I think that 5 lengthenings, we stop lengthening, and she has finished growth with very well balanced spine and with very well corrected deformity. You can see here the pre-op when she was 10 years of age, and the last X-ray in last year, in April of last year. And you can see that the spine clinically is very well balanced and very, very well corrected. So nowadays, we think that it's not necessary to perform definitive posterior fusion after using growing rod, even when the back is very well balanced. I would like to talk about the Vertebra, the rib distractor. I think that the main indication for the Vertebra is the thoracic insufficiency syndrome, which usually appear in congenital deformity of the spine with fused ribs. You can see here a girl of 3 months of age with mixed severe deformity of the thoracic spine. And when she was 15 months of age, we performed a Vertebra, a rib distractor, with expansion thoracotomy. We lengthened many times, and by the age of 7 years of age, you can see here that the curve is under control, and the chest has been increased. The height of the chest has been increased. This is increased the space available for the lung. But I think that is the only main indication of Vertebra. As well, the Charcot-Levy syndrome. This is a boy that he was sent to my hospital from the Emirates with very, very, very severe deformity, especially the chest. The height of the chest was less than 4 centimeters. And in the hospital, he was sent to the ICU because he needs full-time ventilator support. And after tracheotomy, when he was 5 months of age, we performed a bilateral Vertebra in 2 stages, stage 2 weeks in between each in the other one. And we can see the evolution of this girl, of this boy. And by the age of 5, he was able to walk properly. He didn't stay connected full time to the ventilator support. And if we see the last chest X-ray, we see that the length of the height of the left hemithorax is 13 centimeters, and the other one is nearly 9 centimeters. So we have been able to increase the space available for the lungs with the Vertebra. And now talking about the late onset adolescent idiopathic scoliosis, we have to say that despite the continuous evolution in the surgical treatment of the new techniques we use for the adolescent idiopathic scoliosis, the goal remains the same: correct the deformity, balance the spine, fusing the smaller number of lumbar segments without postoperative complications. We can see here one of the techniques we used in the 90s. It's a double anterior-posterior approach with hybrid instrumentation. That means hooks in the upper part, pedicle screws in the lower part, and sublaminar wires. We achieved a very good correction, but the price that the patient had to pay was very high. Long surgeries, double anterior-posterior approach. But nowadays, pedicle screws has become the most popular spine instrumentation. They are placed in the pedicle, which is the strongest part of the vertebra, and they provide a very, very strong anchorage. That the strong anchorage can allow us to correct the deformity without anterior approach or rib osteotomies and anything. We use, for the thoracic spine, the freehand technique. That means that we use anatomic landmark to entry to the pedicle with a pedicle finder. We use our palpator all the time to be sure that there is no any breach in the pedicle, and if everything is okay, we put the pedicle screws. A strong fixation of pedicle screws improve the curve correction. This is normal, but we are very happy because we can obviate the need for anterior release. But this instrumentation decrease the thoracic kyphosis. They improve coronal plane, but they flat the thoracic spine. So pedicle screws show a very good correction, but but they are hypothoracic implants. You can see here that the clinical picture is better, but if you compare the AP sagittal X-ray with the last X-ray, the thoracic kyphosis has been decreased. Even the rib ham has been correct, and the patient is very happy. But very important as well is to know which curve we have to fuse and which curve of the spine we have to respect in the idiopathic adolescence, in the adolescence idiopathic scoliosis. Usually, we use for proper selection of lower instrumented vertebra the concept of a stable vertebra. The stable vertebra is the vertebra which is sagittal bisected by the vertical sacral line. For instance, in this case, L2 is the stable vertebra. So we have to go one vertebra above. The lower instrumented vertebra in this right lanky 1A curve was L1, one vertebra above the stable vertebra, which is the one which is bisected by the vertical sacral line. One of the worst complications till we are using pedicle screws is the adding on phenomenon, which is the progression of the cup angle at the adjacent vertebral level below of the surgical fuse segment. The adding on phenomenon causes the compensation of the spine, and sometimes when the balance is very severely affected, they require revision surgery, like in this case. The stable vertebra was L3, and the lower instrumented vertebra was L1, so 2 levels above the stable vertebra. Immediately, this is the postoperative X-ray, we saw that the balance of the spine will not be good in future. And after that, she developed a very unbalanced trunk, so she required revision surgery, and we added 2 levels more fusions. Something very important is what is the reason for the adding on phenomenon. It's not very well defined in the literature. Wrist fracture seems to be the immature spine. Sponsors wrote a paper, very interesting, that in patients who were 10 years of age and research sign 0 and triradiate cartilage of the pelvis open, the risk of adding on phenomenon was very high. Another, it's the improper selection of lowest instrumented vertebra. And another one, this is more new, is the right tilt of L4. We know nowadays that the lanky 1A types of deformity includes 2 different patterns according to the direction of the L4 vertebral tilt. When it's rotated to the convex is the right. This type of curve is similar to the KIM4 type, and when it is tilted to the left, this is mimics the lanky 1B or the double thoracic curve. to another important point is the deviation vertebra. You published a paper in Spain in 2011 that described the deviation vertebra, the first vertebra in cephalad direction from the sacrum, whose deviation for the central sacral vertical line was more than 10 millimeters. As you can see here, the stable vertebra is L3, but the vertebra which is deviated from the central sacral vertical line more than 10 millimeters is L2. So L2 was defined as the deviation vertebra. Choosing the deviation vertebra as the lower instrumented vertebra very good results. Some examples, for instance, this is a Lenki 1A curve with a stable vertebra of L3 and the end vertebra T12, and satisfactory correction was achieved choosing the lower instrumented vertebra one level above of the stable vertebra. You can see here the lower instrumented vertebra at L2 and very well balanced in AP and lateral and very good correction of the rib ham. Choosing the stable vertebra -2, but including the deviation vertebra in the lower instrumented vertebra can give you a very good result as well. And in this case, you have spare or save one level more. The stable vertebra was L3, but the deviation vertebra was L1. Instead of going to L2, we stop or we choose the lower instrumented vertebra at L1 with a very good result. So the deviation vertebra works in great proportion of Lenki 1A curves. Another example, this is a Lenki 1 left curve, choosing the stable vertebra -2 and the deviation vertebra as the lower instrumented vertebra. We achieve a very good balance without any adding on phenomenon. This is a Lenki 1A right curve, choosing one level cephalad to the stable vertebra as lower instrumented vertebra, which was the same level as the deviation vertebra. We achieved a very good correction. So this is very good. But unsatisfactory result can be chosen when the lower instrumented vertebra is the end vertebra of the curve, sometimes 2 levels above of the stable vertebra, and 1 level above of the deviation vertebra. You can see here the progression of the curve. This is really adding on phenomenon. So choosing 2 levels cephalad to the stable vertebra, but the same level of the deviation vertebra, we can achieve a very good result. This is another example that choosing the deviation vertebra. I think is one of the more important things to choose this vertebra, okay, or 1 level above the stable vertebra. And another important thing is to, in the double curve, to respect as much as possible the lumbar curve. There is a very good paper published in the spine by Steve Richard from Scottish Rite Hospital in Dallas that he described the lumbar gap. The lumbar gap is the distance between the central sacral vertical line and the concave edge of the apex of the lumbar of the thoracolumbar curve. When the lumbar gap is less than 10 millimeters, 1 centimeter, the lumbar curve should be respected. When the lumbar, when the lumbar gap is between 11 and 13 and 15 millimeters, we can spare in 90% of cases the fusion of the lumbar curve. But when the lumbar gap is over 15 millimeters or 20 millimeters, both curves must be fused. So in summary, the lumbar curve should not be used when the lumbar gap is less or maximum 10 millimeters. The lumbar curve should always be fused when the lumbar gap is 20 or more millimeters. And when the lower gap is between 10 and 20 millimeters, other factors that, such as coronal balance to the left, more than 20 millimeters, of the thoracic shift to the left, more than 10 millimeters, should be included in the decision making the lumbar fusion. Okay, so this is all what I wanted to talk to you. Thank you for your attention.